Sunday, webinar number 40. And with your encouraging response and the encouragement of the faculty, we are continuing to do so. And the videos have all been uploaded on YouTube by our channel, Young India Intensive Way. So you can find all the past recordings. I think there are 36 recordings. 3-4 recordings from previous have to be downloaded, and subsequent recordings will be downloaded. So I think it will form a good video book for critical care in the coming time, covering all the topics. And today's topic is potassium, a very elementary thing, a very basic thing, and we'll be talking extensively about potassium. And we all know something about potassium, but there is much more to potassium, and we'll try to sort it out today. You know most of you. My name is Dr. Tapesh Bansal. I'm an intensivist and physician at Gurgaon. And I will just introduce our esteemed panelists. We have with us Dr. Panja, Dr. Inderpaul Singh, Dr. Leelawati and Dr. Reshu. Dr. Panja, you know very well. He has been there with us. Dr. Panja, we cannot see your face in this thing. You have to lower down this thing. You have to sit back a little. I think because your face is not visible, sir. So just adjust your screen.
I think
you have to sit back, I think, a little, because we can see. We can't see your forehead. Okay, so Dr. Soren Panja is actually at Ramindranath Tagore Hospital, Calcutta. He's a HOD of Critical Care and Medicine. Then you know Dr. Leelawati Thakur. She has taken one of the obstetrics critical care, and she has been with us before. She's in West Bengal, and she's in charge of the critical care at Bedon. And Inderpaul Singh sir has joined us for the first time, and we are grateful for him to spare the time. Sir is at PGI Chandigarh, and it's really heartening to have him here because, to involve the premier institutes of our country, it's very nice, and he's looking after the ICU. Actually, my colleague there, Dr. Ashutosh Nath Agarwal, is head of pulmonary department. So I had contacted him. Then he said, Dr. Inderpaul Singh sir is actually looking after the ICU, and he's the critical care man there. So thank you, sir, for sparing your time. And of course, we have Dr. Reshu Gupta Khandelwal, who has been there with us before. Ma'am is from Guwahati, and she's at healthcare. She's the head of the department there. She's also there with us before, and many of you will recognize everybody except Dr. Inderpaul Singh sir. And I'm sure we will see more of him, and he'll probably take some session also for us. So without further ado, I think I'll start now. Whatever questions you have, please put it there. Yes, now it is better, Dr. Panja. We can see you very, very nicely. So please, to the panelists, wherever you want to make a comment or share your experience or ask any questions, please feel free so, because it will make it more interactive. And I will be covering potassium, the physiology part, and hypo and hyperkalemia. So I'll just share the screen, and then we can start. So is the screen visible?
Yes.
I'm audible? Okay, so I'll start then.
Yeah.
A little bit about the history of potassium. The potassium is actually a salt which was first discovered from potash, and it was in the year 1806 by a chemist known as Humphrey Davy. And incidentally, he discovered sodium also. So a little bit about the history of potassium. And coming to the clinical part now, starting the clinical part, if you are in doubt, please recheck potassium. It is very common to get false potassium values. You can get pseudo-hyperkalemia or pseudo-hypokalemia. Pseudo-hyperkalemia is much more common due to poor venipuncture techniques. The sister takes a very small needle, draws the blood fast, there's lysis of RBC, because RBCs contain potassium and they release potassium. And sometimes there is leukocytosis, thrombocytosis, and they can release potassium, and you can get a pseudo-hyperkalemia. Similarly, if there are poor techniques in the lab, you can get false potassium values. And if there is leukemia, then these proliferating cells are supposed to take up potassium and lead to a genuine pseudo-hypokalemia. So we should be aware of the cell count, which can lead to changes in potassium, poor venipuncture techniques, and of course the lab technician has to do it properly. Now, the potassium that we take in is around 100 milliequivalents. It varies anywhere from 60 to 100 milliequivalents in your normal diet, and most of the potassium goes through the kidneys. Most of it, 90% is excreted through the kidneys, 10% is lost in stool and sweat. So this is how the potassium balance is maintained. So the distribution of potassium, one should be aware that it's mainly an intracellular cation, as you can see here. Very little is extracellular, unlike sodium, which is mainly extracellular. And you can see there's a sodium potassium pump on the right, and this sodium potassium pump is very important in maintaining the resting membrane potential. Now, potassium physiology, like I just told you, it's around 60 milliequivalents. You have to give daily if the patient is NPO in the IV drip. So or you can give through the NG, you can give pot chlor, but around 60 milliequivalents would be the requirement if the patient is not taking potassium in any form, that is not on TPN, nor any enteral feeds or oral feeds. So the supplementation can be done either through your IV fluids or through your syrup pot chlor, either way, whichever is feasible. Now, just looking at the kidneys, how the potassium is excreted, if you see here, right in the glomerulus, it is getting filtered through, and here it is absorbed. Then again it is absorbed. So most of it is absorbed initially, and then it is actually it is being removed from the tubules, and then it is put back into the tubules. So it is absorbed and then secreted back into the tubules, and then finally a small amount is lost. So there is absorption and then secretion into the tubules. It is not just that it is filtered through and it goes through. And all this occurs because, the renal medulla is a very complex environment. A lot of molecules are absorbed, a lot of electrolytes are absorbed, and there is a countercurrent mechanism which involves urea and water excretion. So we will not obviously go into that, but that is one of the reasons why it is absorbed and secreted and not just filtered through. And if you look here, aldosterone is a key hormone which increases potassium excretion. And then the other factor which helps in removing potassium, or rather which causes hypokalemia, is a high tubular flow. If you see here in the graph, it is self-evident. So if there is an increased urine flow, your potassium excretion will increase. So what does that mean? That means if there is polyuria, a greater amount of potassium will be excreted. So that is another factor which determines your potassium excretion along with aldosterone. A high aldosterone level will also lead to increased potassium excretion. And sometimes there are defects in the receptors for aldosterone. The aldosterone as such is not altered, but the receptor sensitivity is increased, and these are genetic defects. Then the third factor which determines your potassium excretion is a high sodium load. If the sodium load being delivered to the distal part of the tubules is high, then again your potassium is increased in terms of excretion. So three factors determine your potassium excretion apart from your filtration. One is your aldosterone, which increases excretion. The second is your tubular flow, and third is your high sodium load. Now, I hope the audience here knows the relationship between pH and potassium. There is a very intricate relationship between the pH of the blood and potassium. So, do you know what happens if there is acidosis to potassium? Is there any relationship between acidosis and potassium, and alkalosis and potassium? So the relationship I have shown to you here, if you see here, acidosis causes hyperkalemia and alkalosis causes hypokalemia. Acidosis causes hyperkalemia, alkalosis causes hypokalemia. Please remember that if you don't know. And why does that occur? Why does that occur? There is a reason for that. What happens is when the hydrogen ions increase, that is when you have acidosis in the blood, the hydrogen ions move from the blood to the cells. Okay, and potassium moves out from the cells to the blood. So this is to maintain intracellular pH normal and the blood pH normal, and to maintain the charge equivalent. Because if you move hydrogen from the blood to the cell, your positive charge will increase in the cell. So potassium is also positively charged, so it moves out from the cell to the blood. So what do you get finally? The charges are maintained, you have exchange of hydrogen and potassium, and the pH is corrected. And vice versa you get for alkalosis. So I hope I was able to make you understand that. And it is a very common scenario. Patient goes into acidosis and you wonder why there is hyperkalemia. So please look at your pH to see hypokalemia and hyperkalemia in terms of pH. It is very common to get patients with hypokalemic metabolic alkalosis. I'm sure you must have seen. So what are the common causes for that? One is very important is dehydration. A dehydrated patient coming from outside classically as hypokalemic metabolic alkalosis. Then of course if you are on steroids and if you are on Lasix, these are very common scenarios, and you get hypokalemic alkalosis. Now I told you acidosis causes hyperkalemia and alkalosis causes hypokalemia. This functions throughout the body, but the other way is also correct. That is, hyperkalemia causes acidosis and alkalosis is also caused by hypokalemia, and this occurs at the tubular levels only. Okay, I hope I have not confused you. First is this slide, right? We are talking about the causative factor for hyperkalemia, that is acidosis, and the causative factor for hypokalemia, which is alkalosis, which occurs throughout the body so that the pH is maintained. There is an exchange of hydrogen and potassium across the cells, right? At the same time, whatever the setting may be, not in this setting, if there is hyperkalemia, then it leads to acidosis at the renal tubular level. And similarly, if there is hypokalemia, it leads to alkalosis at the renal tubular level. So there is a very intricate relationship, and you have to figure out which is what, whether it's the hyperkalemia causing the acidosis or whether the acidosis is causing hyperkalemia. Normally you can make out, okay, because which is the primary change? Is it hyperkalemia more severe or is the acidosis more severe? Now we come to certain factors which alter potassium levels in the serum. So there is something known as transcellular shift. I'm sure you are all familiar. Many electrolytes are affected by this transcellular shift, and on the left you can see factors that shift potassium into the cells and thereby cause hypokalemia. So insulin, I'm sure you know. Aldosterone, I've told you, this mainly functions at the renal level. Then beta adrenergic stimulation. So when you give beta agonist, which is a form of treatment for hyperkalemia, you move potassium from the serum into the cells, and then you have alkalosis. Now on the right is factors which shift out, the other way. So you have insulin deficiency like in diabetes, you have aldosterone deficiency like Addison's disease, and you have beta blockers. Beta blockers do not cause much of a change in serum potassium, but they can contribute. And then you have acidosis. Now we come to the last three, cell lysis. So you see, cell lysis is a very important and not so obvious cause, and rhabdomyolysis is very important here, because one, rhabdomyolysis can occur in any setting and it releases potassium. 75% of the entire body potassium is in skeletal cells, skeletal muscles, right? So rhabdomyolysis has many causes, and when there is rhabdomyolysis, the skeletal muscle cells release potassium. Now there's another situation where hypokalemic patients, if they undergo some degree of exercise, it can lead to rhabdomyolysis also. So hypokalemia can lead to rhabdomyolysis if the patient does some exercise. And the textbooks say it can cause otherwise also extreme hypokalemia, but I have not seen that. Maybe anybody wants to comment on this, sir? Rhabdomyolysis occurring in the setting of hypokalemia? Dr. Soren, sir?
Yeah, Dr. Bansal.
Yeah.
What actually your rhabdomyolysis, hypokalemia causing rhabdomyolysis? You are talking about that.
Yes. You have any experience hypokalemia? You have seen anything like this?
Personally, I have not seen that directly hypokalemia contributing to the your myonecrosis or the rhabdomyolysis. I have not seen any case.
Yes. Anybody else has any experience with this? Hypokalemia leading to rhabdomyolysis?
Actually, we have seen the other way around. Rhabdomyolysis causing hyperkalemia.
Yes, that is definitely there, ma'am. But it is stated everywhere.
I haven't ever seen a case, but it's written all over in the textbooks that severe hypokalemia may cause cell damage and create rhabdomyolysis.
Yes. And it also says that it is mainly if the patient is exercising, because when the patient is exercising, hypokalemia reduces the blood flow in the muscle cells. That is the explanation given, but it is there everywhere, so must be occurring occasionally. I have also not seen this, but definitely rhabdomyolysis causes hyperkalemia. Then the other kind of cell lysis is tumor cell lysis. When you have tumor cell lysis, then any acute liver failure with the necrosis of the liver cells. So any cell lysis can give rise to hyperkalemia because potassium is released from the cells. Then strenuous exercise leads to potassium release from the musculoskeletal system and increased extracellular fluid osmolarity. So I hope you are aware of increased extracellular fluid osmolarity. Which condition does it occur in? When this last cause, increased extracellular fluid osmolarity, is which condition? This is mannitol. Mannitol causes something known as solvent drag. Okay, it is because mannitol draws water from the intracellular to the extracellular space. It draws potassium along with it, and the term used for this is solvent drag. Similarly, if there is significant hyperglycemia, then also it draws potassium out. So hyperosmolar state due to mannitol or concentrated solutions of dextrose lead to solvent drag and cause some degree of hyperkalemia. So in a nutshell, a very important consideration is transcellular shifts of potassium, which can either increase or decrease serum potassium. Now, a little bit about the physiology in terms of conductance. So, this is the cell membrane here, and this is outside the cell, this is inside the cell. And a very fundamental role to potassium is to maintain the resting membrane potential. Okay, that is a key feature of potassium homeostasis. And the resting membrane potential is maintained here, and the outside of the cell is positive as compared to inside of the cell. And this is actually maintained to a great extent by pumping out 3 sodium and pumping in 2 potassium. So this maintains positive outside and negative inside, and this is actually a very important factor because this determines your transmission in the neuromuscular area as well as in your cardiac cells. So this is the key to your cardiac arrhythmias and your neuromuscular symptoms when there is alteration in this resting membrane potential. And normally this resting membrane potential is -70, with inside of the cell being negative as compared to outside. So now what happens in conduction of neuromuscular transmission? As I told you, -70 is the usual resting membrane potential, and when there is a nerve impulse, there is depolarization, which leads to your transmission along the nerve fiber and your depolarization of the muscle, and it leads to contraction of the muscle. Now, when your potassium levels decrease, this resting membrane potential actually decreases. It becomes around -50, -40, whatever, depending on your potassium levels. Because this -70 is determined by the extracellular to intercellular potassium ratio. Okay, this -70, which is your resting membrane potential, which determines electrical transmission, is determined by your potassium ratio, intracellular and extracellular values. So when the potassium here outside the cell becomes less, then this resting membrane potential becomes less negative, and when it becomes less negative, transmission decreases. And transmission decreases means muscle contraction decreases, muscles become weak. So that is the key physiology in the neuromuscular symptoms of hypokalemia. And similarly, in your cardiac potential, action potential and resting membrane potential, we see here, this is the action potential in the cardiac conduction fibers. And you can see here, this is potassium and there is movement of potassium. So similarly, when you have potassium disturbance in terms of hypokalemia or hyperkalemia, your electric potential in the cardiac fibers, your Purkinje system changes, and thereby you get the disturbance in your conduction and the different types of arrhythmias. Beyond that is not within the scope of critical care, and we will not delve into it. Beyond that is meant for cardiologists. But suffice to say, this is how potassium causes neuromuscular symptoms, and this is how it causes your cardiac arrhythmias. So coming to the clinical features of potassium, so there is loss of deep tendon reflexes, there are electrocardiographic changes, there is muscle weakness leading to respiratory failure and ventilation, there are muscle cramps, muscle pains, muscle weakness, and very importantly here is ileus. Please do not forget, hypokalemia is a cause of ileus. Patients in the ICU stops passing stool, abdomen starts getting distended, and you wonder what is happening. You don't see the potassium. Many a times it is a potassium of 2.53, which is the problem. You give some potassium and the patient regains bowel movement and the distension decreases. This is not so uncommon, and please do not think that the patient is actually going into some kind of a surgical abdomen. This is not so infrequent. It happens occasionally. One forgets to see the potassium. Now, you are faced with a situation where your potassium is low. So, I would like to just take the opinion of the panel, how they would like to, approach the potassium. How do they approach the potassium, and what do they think is the commonest cause in their ICU of low potassium? So, anybody could please try to comment on this.
Generally, hello?
Yes, please carry on. You are hearing.
Recently, we had got a potassium, got a patient with severe hypokalemia. So, we had proceeded like this. We had checked for urinary potassium level. And generally, urine potassium, if it is less than 20, we generally think this is an extrarenal loss, and actually patient had urinary potassium of 57, so it was a renal loss. And renal loss, once you are confirmed that it's a renal loss, then you please check the acid base status of the patient. If acid base status is normal, then please check hypomagnesemia. This is one of the major cause of hypokalemia, and which is refractory hypokalemia unless you correct the magnesium. ATN and post-obstructive diuresis is also a cause for normal acid base balance patients. If the patient is having metabolic alkalosis, then you have to check urine chloride as well. Again, urine chloride less than 10 milligram per liter, then probably he has got NG suction and vomiting frequency, and he or she is recovering from diuretic use.
Ma'am,
If
so
he
this patient came with how much potassium?
this patient had presented to us with 1.5.
1.5. Huh?
Yes.
So what, that was he came from outside. So what is the primary diagnosis?
He came with altered sensorium and severe, muscle aches and pain.
So this is hypokalemic symptoms he came with. So he was
Yeah,
dehydrated. Probably he was dehydrated, right?
Significantly, yes. He had U waves and depressed ST segment in the ECG. Then now, if the urine chloride is more than 10 milliculent, please check the blood pressure. And actually, this patient was also a hypertensive one.
Oh,
hypertensive,
yes, right?
Hypertensive one, and we had diagnosed him as to be primary hyperaldosteronism case.
So he turned out to be primary aldosteronism.
Primary hyperaldosteronism.
Oh, so he was primarily aldosteronism. So
Yes.
The cause of his altered sensorium was what? It was alkalosis.
Yes, alkalosis. He had 7.611 was the pH.
Yes. Very interesting.
If you find a metabolic acidosis, then you please consider the RTA, renal tubular acidosis, type 1 and type 2, diabetic ketoacidosis also, and alcoholic ketoacidosis. These are the causes for hypokalemia.
Yes, this is very interesting. So he has a private aldosteronism and hypokalemic alcoholism.
Just a comment, Dr. Leela. What do you think that cause for this altered sensorium?
He had also the hyponatremia as well.
Okay.
Along with that. Another thing is that if the blood pressure is normal with high urinary chloride, then you consider Bartter syndrome or Gitelman. These are also more or less common in our part of the country.
Ma'am, this is very interesting. You are seeing Bartter and Gitelman also.
Bartter and Gitelman also we come to see.
Oh, that is very interesting. So we will talk about it. You please share your experience after this. And Dr. Inderpaul, sir, any comments?
I think.
So what kind of hypokalemia?
It is multifactorial, and when a patient comes to us with hypokalemia, we revisit the history, and either there is decreased intake or there is excess loss. So common cause is generally chronic diuretic use, especially in patients who have got heart failure or who are hypertensive. Obviously, GI loss is another cause. Occasionally, you will see patients with metabolic acidosis and hypokalemia, which is, and then you need to think in terms of renal tubular acidosis. I think it has to be a multi-pronged approach, and you need to just categorize as whether it is the reduced intake or excessive loss, as ma'am has said rightly. Generally, it is multifactorial, so you need to take care of other stuff also.
So you see any of these Barters and Gitelmans in your Chandigarh area?
We just had a case recently. The patient actually presented to us with encephalopathy. She had seizures. She also had hypothyroidism, so diagnosed as Hashimoto's encephalopathy. She had type 2 RTA, so on further workup, she turned out to be Sjogren syndrome. So you see, you have to keep following the algorithm that comes along. So because she had acidosis, so she had other autoimmune features of Hashimoto's. We thought in terms of sending the autoimmune workup.
Yes, RTA is very Sjogren's is one of the key conditions where you get RTA, distal RTA, absolutely. And we will talk about Barters and Gitelman as we go along. I have some slides on that.
Just one thing I would like to add, like we recently got a patient, very recently, just discharged 3 days back, thyrotoxic periodic paralysis. This is also one thing which we learned. So as Dr. Leelawati and Dr. Sehgal have rightly said, if we go in a very systematic approach to hypokalemia or hyperkalemia, coming to the diagnosis, the cause of the electrolyte imbalance becomes very easy. So we just maintained the protocol. We just were very systematic. And when we ruled out everything, then later on we could diagnose this patient as thyrotoxic periodic paralysis.
So this patient was having hypokalemic periodic paralysis with
Yeah.
thyrotoxicosis, right?
Yeah.
Okay. So because he must have come with a low potassium, and then you must have sent the TFT.
He came presented with quadriparesis, very
Yes.
tingling sensation and weakness of all the 4 limbs.
Excellent.
So then we proceeded.
Yes. Because this actually hypokalemic periodic paralysis is the association with thyrotoxicosis is particularly common in Asian people.
Yeah, very much.
So whenever you get hypokalemic periodic paralysis, we should always send thyroid function, because the thyrotoxicosis is not covert; it can be subtle. So you may not be having Freud symptoms of thyrotoxicosis. So that is very good. So I think Dr. Soren sir, your you have vast experience. Any comments from your side on potassium?
No, regarding that, I fully agree with other panelists or whoever has given good proposal. Dr. Singh, what he has mentioned, actually we should start with the good history taking, because most of the time from history we can get some diagnosis or some clue, and sometimes in the critical care there are enough number of cases where it is mostly multifactorial, mostly. And about the gentleman or butter, I don't have much experience on getting those kind of but definitely these are sometimes which actually we can see that algorithm, follow that algorithm, metabolic alkalosis, or then you can check the about the only potassium your excretion through the kidney. I just want to comment, because lot of patients are getting diuretics, so that history of diuretics is very important, because if the patient is in a polyuric phase or active diuretics, just shortly 1 or 2 days before patient stop, so that time it can camouflage their values. So that's why ideally the checking of the serum potassium, whether the patient is polyuric or oliguric, both can actually change the interpretation. So that's why we should be keep some caution on interpreting that potassium excretion in the background of hypokalemia. If the patient is either polyuric or oliguric or low urine output, then we should actually keep it in mind also.
Yes.
And obviously after that, gradually after taking history as well as try to find out the cause, then acidosis, alkalosis, then we can go by that algorithm. Okay, I think that is a good point actually.
Yeah. Okay, thank you, sir. Thank you to all the panelists. So friends, just to summarize, rare causes are not uncommon in potassium, though obviously common causes are always more common. Like emphasized by Dr. Panja and Dr. Inderjeet Paul Singh, sir, that you have to look at the drugs, you have to look at the intake, you have to look at Lasix, thiazides, and you have to look at the acid-base balance, like I've shown you here, and you have to look at the renal losses. Then you have to look at magnesium and transcellular shifts, which I showed you very clearly. So these are the features, main determinants of low potassium. If you think of these 6 broad categories, you will be able to fit in your hypokalemia somewhere. And please remember, no list is ever complete. There are always extremely low causes, very rare causes. For example, there's a megaloblastic anemia, right? And you give him some folic acid, there's massive cell proliferation. He gets hypokalemia because the proliferating cells consume potassium. So there are always a few causes which may be very difficult to sort out unless you look up the table. So that is about an approach to potassium. I look at it this way: 6 broad categories, and I have generally been able to sort out why my potassium is low. You see, as intensivists, we have to go beyond just correcting potassium. Okay, we have to understand where the potassium is going, where we are losing potassium, why the potassium is low. Most of my young people, they are happy correcting the potassium. But as you grow up, you will realize one has to understand why potassium is low, because it is not in isolation. There is acidosis, there is alkalosis, there are drugs. So you should try and understand why your potassium is low. So I hope I've been able to shed some light on this along with my panelists. And now we shall move on to the next slide. So rare etiologies of low potassium, which we have just talked about. So some of them are hypokalemic periodic paralysis, and sometimes you can get even normokalemic periodic paralysis where the potassium is normal, and there's an entity called hyperkalemic periodic paralysis, but that is restricted to a pediatric age group. Then we have distal RTA. RTA stands for renal tubular acidosis. We have proximal RTA. We have Liddle syndrome. We have Gittleman syndrome, and we have barium poisoning. I have not written, Bartter syndrome because, to the best of my knowledge, Bartter syndrome is mainly in the pediatric age group. It is very rare to have it in adults. And Gittleman is actually the adult variant of Bartter syndrome in terms of its physiology and its changes. Maybe Dr. Leelawati ma'am can shed more light because she's seeing a lot. Probably there's some genetic pocket there which throws Gittleman and Bartter syndrome and Liddle syndrome. But I have personally, I've been in Gurgaon and Delhi for a long time. I have not had the opportunity to see Liddle's, Gittleman and Bartter syndrome. And then you have barium poisoning. So where do you get barium poisoning? Where do you get barium poisoning? Barium poisoning is actually seen in forms of rodenticides. Certain rodenticides have barium. So barium poisoning, well, I've seen a couple of cases, potassium becomes less than 2. It becomes less than 2. So if in the setting of a poisoning you are getting extremely low potassium, do think of barium poisoning. Now, just the key feature of Liddle syndrome, it is actually hypokalemic alkalosis and hypertension. So if you're getting hypokalemic alkalosis and hypertension without any obvious cause, and it is going on for some time, think of Liddle syndrome. Gittleman syndrome is hypokalemic alkalosis again, but it does not have hypertension, and a key feature is hypomagnesemia. Key feature is they almost always have hypomagnesemia. And then refractory hypokalemia, I've just told you, is barium poisoning. So these were some of the rare disorders, and now I'll just talk about renal tubular drugs first and then renal tubular acidosis. So there is a list of drugs. Dr. Panja has mentioned diuretics, then aminoglycosides. Please remember that aminoglycosides can cause hypokalemia by causing tubular dysfunction without causing renal failure. The creatinine may be normal, they just cause hypokalemia. Then your nebulization, because I showed you earlier, it causes transcellular shifts. Nebulization is with beta-2 agonist, not with the ipratropium. Then insulin, again transcellular shift. Steroids, because they cause losses in the urine. Phosphomycin is a very important drug. After giving 2-3 days of phosphomycin, a very high percentage of patients go into severe hypokalemia to the tune of potassium going down to 2, actually 2, 2.5, 2.2, and this again occurs because of tubular dysfunction. And the way to correct it is you can slow the infusion. That is the recommendation. Normally we give phosphomycin over half an hour to 1 hour. You slow the infusion rate to 3 hours, and your hypokalemia will decrease. And you can probably add spironolactone, because going on giving potassium does not really help in these patients. Then amphotericin and even high dose penicillins. So this is a list. Of course, there will be a few more drugs, but generally these are drugs which we commonly use, and you should be aware of these drugs. And then in renal, Dr. Leelawati ma'am mentioned polyuria and polyuric phase of AKI, and even early phases of tubulointerstitial diseases, which are actually part of CKD. So we all know CKD causes hyperkalemia. You may wonder what I am saying. But yes, in the early stages of CKD, which are primarily tubulointerstitial, for example, chronic interstitial nephritis, right? So these diseases start from the tubules rather from the glomeruli. And when they start from the tubules, because the tubules are involved in potassium absorption and secretion, potassium gets affected primarily, and there's a loss of potassium. Later on, the glomeruli also get involved, the GFR decreases, and they go into hyperkalemia. But there is a subgroup of CKD known as tubulointerstitial diseases, which in the initial stages can have hypokalemia, and they have polyuria, these patients, in the beginning. And polyuric phase of AKI, because due to the washout of the urea load and the solutes which have been retained, you get a washout of your solutes, and along with that you get your potassium washout. And polyuria, I told you, if there's a high flow rate in the tubules of the urine of the kidney, you get a washout of potassium. Now, coming to hypokalemic periodic paralysis. So, what are the clinical features of hypokalemic periodic paralysis, which we all see? No matter where we are practicing, I think every ICU gets 1 or 2 cases per year, depending on the population it is catering to. But definitely, we see this. So, onset is at a young age, and normally patients are less than 25 years old. In fact, onset of quadriparesis or muscular weakness after the age of 25 as a first episode goes against the diagnosis. And family history is often obtainable if you ask for it. And the patient may have had previous episodes also. He may or may not give it. Patients give all kinds of history. You are not able to elicit sometimes. He may come with the first episode. Then exercise, carbohydrate meal, and stress are precipitants of this paralysis. Now, why are these precipitants? Because you see, exercise and carbohydrate meal and stress cause inward movement of potassium. So they become precipitants because carbohydrate meal leads to insulin. So insulin causes inward movement. Similarly, exercise is a known factor which causes inward movement. So these factors cause hypokalemia and precipitate the episode. Then potassium less than 2 is extremely rare in this periodic paralysis, and the distribution is proximal more than distal, lower limb more than upper limb, but often they come with quadriparesis. And the physiology is that it is a membrane channel disorder. It's called a channelopathy. The various sodium, potassium, calcium channels get altered, so there is an inward movement of potassium, transcellular shift. The total body potassium is not altered. Okay, the total body potassium is not altered. There is a movement of potassium from the blood into the cells, leading to decreased serum potassium and periodic paralysis. Now, because the potassium moves into the cells, when the episode subsides, potassium is going to move back from the cells to your blood. So you have to be careful in giving the total amount of potassium, because otherwise you get rebound hyperkalemia. And like Dr. Reshu said, thyrotoxicosis is often accompanying these patients who have hypokalemic periodic paralysis, and thereby TFT should be sent in all these patients. This is particularly common, the association of thyrotoxicosis with hypokalemic periodic paralysis in Asian population. And your thyrotoxicosis may not be florid. Just the thyroid function test will reveal abnormality, and on questioning you may get minimal features. At other times, of course, you may have more florid features of thyrotoxicosis. Then we come to distal RTA, which is known as type 1, which Dr. Inderpaul Singh sir said he had this patient who had Hashimoto's encephalopathy, and then he had Sjogren syndrome, and then they found acidosis, and they came to RTA distal type. There are 2 types of RTA, distal and proximal. We will discuss them as we go on. So what are the clinical features of distal RTA? It has acidosis, and bicarbonate can be even less than 10. I had a patient once actually who came to the ICU with weakness and generalized malaise, because there's chronic acidosis. They go into generalized malaise, and because of hypokalemia, generalized muscular weakness, and she had been put on spironolactone. She was carrying 3-4 reports of low potassium. Nobody had been able to figure out, and she had been put on spironolactone because spironolactone causes high potassium levels. It decreases the secretion of potassium. So I sent the ABG because ABG had not been done. ABG revealed an acidosis, and I calculated the anion gap. Anion gap was normal. So once you know the causes of normal anion gap, there aren't too many causes. So by diagnosis of exclusion, it becomes renal tubular acidosis. You have your urine gap also, urine anion gap, but that is not really required. All textbooks will say to diagnose RTA, use the urine anion gap, but urine anion gap is not required. You just see the potassium, see the bicarbonate, and see there is normal anion gap acidosis, and then there's something else which can be done. So I've highlighted that these patients develop nephrocalcinosis. They develop nephrocalcinosis. So get a plain abdomen X-ray showing the kidneys and the bladder, you will get stones. This is a classic feature of distal RTA. And stones develop in these patients because there's loss of citrate in the urine, because it is a tubular defect. The renal tubules are defective. And these are complex disorders in the tubules which are beyond our purview. We do not need to know the details of these tubular changes. Suffice to say, the tubular changes lead to citrate loss, and because of acidosis, there is hypercalciuria. The acidic milieu dissolves the bone. So there is increased serum calcium, which leads to increased excretion of calcium. So because there is increased excretion, the serum calcium remains normal. There is no hypercalcemia as such. And this occurs because of a defect in the distal part of the renal tubules. It can be isolated or part of a systemic disease, and classically Sjogren's syndrome. The most classic disease, which is an autoimmune disease, is Sjogren's disease, with which it is associated. It can, of course, be associated with many other autoimmune diseases, or other diseases can be genetic, can be isolated. So it comes in various shapes and sizes. Now, what is this defect in distal part of renal tubules? So for that, you have to understand the process in which the body reclaims acid that is produced in the body. This is a process of acidification of the urine. So I will try to explain this to you. So let's see if you can, kind of make it out. So treatment, actually correct the potassium first, and then you have to put them on oral supplement and alkali supplement, and try to give them a potassium rich food. It is a chronic disorder. There is no permanent treatment, and the patient I discharged was non-compliant to treatment. Occasionally she should take some pot chlor, and salt solution was the solution I gave for alkali, but the taste and all is not good. It's very difficult for anybody to take it every day. She was taking some potassium rich food in the form of citrus juices, etc. But eventually something else happened to the patient. She had a RTA and she expired. Not related to this, of course. Now coming to type 2, that is proximal RTA. So this is more in the pediatric age group, and if you remember, there's something known as Fanconi syndrome. So that is a type of RTA, and in this you have, along with the loss of bicarbonate in the urine, you have glycosoluria, amino acid urea, and your serum bicarbonate is around 12 to 20, and again it's a normal anion gap. The key here in your renal tubular acidosis is that your bicarbonate will be low, your pH will be low, and it will be normal anion gap. And to distinguish type 2 from type 1, see the stones in the X-ray. In early distal RTA, you may not get stones, but eventually, by the time the patient comes to you, normally you will have stones. It's quite classic. So that is how you differentiate between type 1 and type 2. Now, to make you understand why it is proximal and distal, you have to understand how the body handles the acid. You see, 80 milliculents of acid are normally produced daily in the body. And this 80 milliculents is actually handled by the bicarbonate, right? So 80 milliculents of hydrogen ions are neutralized by the same amount of bicarbonate. So bicarbonate is consumed. Now, there is some serum bicarbonate also. So when this is filtered across the glomeruli, your bicarbonate is getting filtered. This filtered bicarbonate is absorbed in the proximal tubule. This filtered bicarbonate has to be absorbed, otherwise you will lose the bicarbonate. So whatever is filtered through, that is absorbed, and if there is a defect in the proximal tubule, which is there in this type 2, the bicarbonate goes out. Thereby you get acidosis. Now in distal RTA, what happens is that the proximal part is okay. Whatever bicarbonate is being filtered through is absorbed. But you have to generate 80 milliculents of bicarbonate, which were used to neutralize the daily production of 80 milliculents of hydrogen. And this generation of bicarbonate occurs in the distal tubules. So the distal tubules are defective. You cannot generate this bicarbonate, thereby leading to acidosis. So that is actually the key pathophysiology of proximal and distal, and along with that you get hypokalemia, because that is part of the tubular disorder that you have in this. So I hope I was able to make it clear. That is in key proximal and distal RTA. You have to be worried about distal RTA more than your proximal. Proximal is generally a pediatric disorder. Now we come to a very interesting point here, and I would like the opinion of the panel. You know, we don't normally give IV potassium as a bolus or as a fast push, but supposing the patient is having, you know, a very unstable ECG right in front of you, can we push in IV potassium? So if anybody would like to, you know, voice his opinion on that from the panel, please. What is to be done in such a situation? Right in front of you are standing potassium is something like 2 and 2.5, 2.2, and ECG is degenerating. Would you like to push in potassium? Because we all know don't give IV potassium fast. Okay, so the answer is yes. In this only one situation, you should, under electrocardiographic monitoring, take 20 millicuries in 50 ml syringe and just slowly push it. This is the only situation where you can give potassium fast. I mean, you should not just shoot it immediately. Thoda sa aram se, just push in potassium, and as the ECG stabilizes, stop the potassium push, and then you correct the potassium in a slower fashion.
One thing.
It will be a very.
Yes, ma'am.
Yeah, Dr. Leelawati, go ahead.
Any comments?
I mean, if there is a potentially harmful cardiac arrhythmia that may translate into ventricular fibrillation and later on asystole, you have to give a push, not very fast, as you have already said, Dr. Bansal. So along with that, I think magnesium will have to be given to, protect the heart from the arrhythmia. So magnesium is as well necessary to counter the the arrhythmic effect of hypokalemia. So both magnesium and potassium, if it can be given simultaneously, I think it's better to get
yes.
the.
Yes,
Yeah.
your point is well taken, ma'am, because hypokalemia actually predisposes to torsade. So if there is evidence of torsade going on, definitely magnesium also will help. I agree.
I was about
Any other comments, sir?
Because we had an experience of severe hypokalemia.
Okay. Then should we move on? I think we'll move on here. So I think, ma'am, you would like to comment upon Gittleman syndrome and a little bit of your experience with this.
You continue it on.
Okay.
Actually.
So now you see, this is the approach given in classic textbooks of medicine and nephrology to getting the diagnosis and sorting out your hypokalemia and hyperkalemia. And you see, this is very complex, and to even look it up will take one full day. And in the ICU, you cannot do this. Neither can you put it in your brain or in your. I mean, this is not possible, right? You can probably go through it once and try to understand it, but this is not required. This is just to kind of help you understand what is happening. And at the end of the day, what I showed you in the slide, there are 6 broad categories, and of course, there are rare etiologies. If you put your potassium into that, you will get your answer for hypokalemia. And please remember, rare presentations of common disorders is more common than common presentations of rare disorders. We have these rare disorders, RTA and Gittleman's and Barter's and hypokalemic periodic paralysis, but they are rare, once in a year kind of a thing. But the other etiologies are much more common, and those have to be sorted out in order to optimize the treatment for your patient. Now, what is the best test to find out the etiology for hypokalemia? So the best test is actually, you can do a 24-hour urine potassium. If you can collect the 24-hour sample and this distinguishes extrarenal losses from a renal cause. That is, if your excretion is more than 13, it means there are renal losses. And less than 13 means it is actually not losing in the urine. If you cannot do a 24-hour, then you can actually do a urine spot potassium to creatinine. So again, the value is 13. And if it's more than 13 means renal losses. So this is a very nice test which I have done sometimes, occasionally. And this is the one I recommend because 24-hour collection is a problem. The sisters will not do it, you know, how it is in our ICUs. I should not say like that for sisters, but collection is a problem. And 24 hours often is not correct. You know, one sample will be thrown away or something or the other. This is much more easy and feasible and validated. So this is the test you can do. This differentiates renal and extrarenal. So if it is more than 13, means you are losing in the kidney in the urine, and less than 13 means it is not being lost in the urine. The cause is either there is a transcellular shift, or you are losing in the GI tract, or your intake is less. So one of these causes which I have outlined earlier. Now this is actually showing you all the ECG changes. I will not go through everything, but I will just like to highlight one or two things. First of all, you know, Brugada type patterns can be seen in severe hyperkalemia. Severe hyperkalemia, Brugada, is a syndrome which actually causes sudden cardiac death. So some of you may be knowing who are good at ECGs. Then ECG triad of peak T waves from hyperkalemia, QT, ST prolongation, and LVH from hypertension is strongly suggestive of CRF. So this is a triad: peak T waves because of hyperkalemia, QT prolongation from hypocalcemia, and LVH from hypertension is strongly suggestive of CKD. So as far as the ECG is concerned, I will not go too much in details. I think it's given everywhere and you all know, but I will touch a few critical points. So this is actually showing what? Anyone from the audience wants to put in the chat box? This ECG is showing what? Hypokalemia, hyperkalemia, or normokalemia? Any answers are there, ma'am? The question is this ECG showing hypokalemia, hyperkalemia, or normokalemia?
I think there is no messages found in chat.
Okay, so this is actually
Hyperkalemia.
this is actually showing day 1 and day 2. On day 1, potassium level is 6.5, and you can see here, if you see here, QRS widening, and here you see potassium is returned to 5.5. These are T waves which are tented, peaked, and here QRS is widening at 6.5 potassium and tall T waves. So now if you look at this, this looks like, you know, ventricular tachycardia. Supposing this patient had hyperkalemia and he had sinus tachycardia, right? Rate of 150. So this would mimic ventricular tachycardia. It is not uncommon for CKD patients to present with heart rate 150 and hyperkalemic changes of this kind, and one thinks the patient is in ventricular tachycardia. So that distinction should be made because this is wide QRS tachycardia. The QRS complex widens and the P wave actually disappears, or when there is a significant tachycardia, you know, there is a the P wave cannot be discerned. So one should be cognizant of this in CRF with hyperkalemia, with sinus tachycardia. You can mistake it for ventricular tachycardia. And this is a classic tented T wave. What is a tented and a tall T wave? So tented is like this. Normally the contour is round, and a tall T wave is more than 10 small squares. You count these number of squares, more than 10 small squares. However, if the QRS complex itself is small, then there is no actually number which tells you what is a tall T wave. It is subjective. Now this shows you actually hypokalemia here, and if you go through the ECG, you will realize here this is day 1, potassium is 1.9, and you have ST depression here. You can see the ST depression, and when you have ischemia, then also you get ST depression. So if the cardiologist is seeing or someone else is seeing, you can mistake this ECG for ischemia. Then this is not a T wave, this is actually a U wave. So discerning a T wave from U wave actually is not so easy, and ST depression is occurring with a T wave here, U wave, and as the potassium gets corrected, you can see the ST is returning and there's a nice T wave. And you can see here there's QT prolongation. It is actually called QU because T disappears and merges with U. And this hypokalemia can predispose to torsade. Torsade pointes, and like Dr. leelawati ma'am said, if you are pushing in potassium, you should also push in magnesium if they have a tendency to go into torsade, because hypokalemic patients who are severely hypokalemic can go into torsade. Now, this is a very important slide here, and just have a look at this slide before I tell you. This is the treatment of hypokalemia, and this should be known to everybody very clearly. Okay, so and I have looked up the references very clearly so that there is no confusion. So please have a look, and then I will just go through this. So I think you have all gone through it. Now the question is, first of all, correction of potassium, routine hypokalemia should be done ideally through syrup pot chlor, because it goes slowly, easy to give, no thrombophlebitis, and many a time patient does not have a central line. And you can give up to 100 millicoulomb. 15 ml of pot chlor has 20 millicoulomb. So that should be known to everybody. 15 ml of pot chlor has 20 millicoulomb of potassium. But the patient does not tolerate 100 millicoulomb because it causes gastric irritation. But yes, 15 to 20 ml TDS is tolerated by the patient. It is not so difficult to give. So either orally or through the NG. Now the question comes, if you have to give through the peripheral line, you have a central line. So you can give 40 millicoulomb in 500 ml NS. Please you do not use dextrose generally as a medium, because dextrose leads to insulin release, and insulin release actually causes transcellular shift and hypokalemia. So wherever you are correcting hypokalemia, dextrose infusion, dextrose or DNS should be avoided. And the infusion rate is up to you, but 10 millicoulomb per hour is normally what you give. Now supposing you want to give a concentrated solution through the peripheral line. You don't want to give 500 ml, patient is in fluid restriction. So can you give through the peripheral line, let's say 100 ml? Yes, you can give a small amount, and it is, you dissolve 1 ampule, that is 20 millicoulomb, in 100 ml at 10 millicoulomb per hour. I repeat, 20 millicoulomb in 100 ml over 2 hours, and that can be repeated once. So 40 millicoulomb over 4 hours in a total of 200 ml divided into 2. Don't give 40 into 100 ml, because if you run it fast, the patient can go to cardiac arrest. The main concern in giving potassium through the peripheral line is, one, you can run it fast and cause cardiac arrest. Second, thrombophlebitis. So this much you can give through the peripheral line in a concentrated amount if there is fluid restriction. Now, if you are giving through the syringe pump, what is the maximum concentration through the central line? It is 20 millicoulomb per 50 ml. So please be very clear about this. This is something which we practice, most of us, and this is what it is. There should be no confusion about this, because sometimes people give different kinds of concentration. What is the maximum concentration? So this is 20 millicoulomb per 50 ml through the central line. This is the concentration, and the infusion rate can be whatever you want, 10 to 20 millicoulomb per hour. If there is severe hypokalemia, then 10 to 20 to 40 milligrams per hour is usually given. And if there is very severe hypokalemia, the ectopics, respiratory failure, cortiparesis, and severe hypokalemia, up to 80 milligrams per hour maximum infusion, and this is given through 2 central lines, and one has to be femoral, because when you give through femoral, it gets diluted and does not hit the heart directly. You see, when you're putting in the central line might be touching the endocardium, and if you're giving a lot of potassium, it can irritate the endocardium and set off arrhythmias. So when you give through femoral, it actually gets diluted by the time it reaches the heart. And that is the reason actually why 20 milligrams per 50 ml and not a larger concentration is given through your syringe pump. Because by concentrating it further in your syringe pump, a very concentrated amount will hit the endocardium, and that will trigger off arrhythmias. And the second thing is, of course, the sister can make an error and push it fast, and you can have a cardiac arrest. So this actually is a very important slide, and please take note of this. I hope I've been able to clarify my position here. And the other thing is spironolactone, which I told you for phosphomycin, or wherever the kidney is losing, you can add tablet spironolactone. It retains potassium. It's a useful thing in the ICU. And of course, all other factors should be taken care of which are causing hypokalemia. What is the cause of hypokalemia? And magnesium is very important here, like Dr. Leelawati ma'am said earlier. And why is hypokalemia not corrected if there is hypomagnesemia? What is the physiology? The physiology is that magnesium is responsible for absorption of potassium in the renal tubules. If there is a magnesium deficiency, then the channels which are responsible for absorption of potassium in the renal tubules become dysfunctional, and there's a continued leak of potassium. So you push in potassium, but the potassium is not absorbed, and you lose it in the urine. Thereby, you get refractory hypokalemia. We are all aware of this, that you have to look at magnesium if there is refractory hypokalemia, but the reason is what I just told you. Now, another thing which is given in the books is TTKG, transtubular potassium gradient. Okay, this is more for hyperkalemia and somewhat for hypokalemia. But this is a very difficult formula to use, because urine osmolarity by plasma osmolarity has to go outsourced. We don't do it normally in our labs. And this is actually in the sequence of events which were shown in the flow chart earlier, and I've never used it, but this is there if somebody wants to use it. And this is the formula, and on the basis of this, you further categorize what is the cause of your hyperkalemia, and it is not so much for hypokalemia, it is more for hyperkalemia. Now, the question about diabetic ketoacidosis and potassium. What happens to potassium in diabetic ketoacidosis? So, in diabetic ketoacidosis, first of all, there is hyperglycemia. This hyperglycemia leads to osmotic diuresis. When there is osmotic diuresis because of polyuria, potassium is lost in the urine. It just gets washed. So, the total body potassium becomes low. But because there is severe acidosis, there is movement of potassium from the cells into the blood. So that is actually the physiology of potassium. On one hand, you lose potassium in the urine because of hyperglycemic osmotic diuresis. On the other hand, potassium moves out from the cells to the blood because of acidosis. So the potassium level can be varying. When you get diabetic ketoacidosis, so normally the potassium is low normal. And one of the key features in the treatment is that if the potassium is less than 3.5, do not give insulin, first correct the potassium. Because the moment you give insulin, your potassium will move back into the cell and further cause hypokalemia. And if there is, a potassium more than 5.5, the moment you give your fluids and your insulin, the potassium will fall. And the total potassium deficit is to the tune of 400 milliequivalents in diabetic ketoacidosis, and it takes 2-3 days to correct the potassium. It takes a long while because the deficit is so much. So please be aware of this, and you may correct the pH, you may correct the ketosis, but the potassium gets corrected the last actually. And don't leave the potassium. You have to monitor potassium 6 hourly when you are correcting diabetic ketoacidosis. And the other thing is there any formula for estimating your potassium deficit? If your potassium is 2.5, how many milliequivalents does the patient need? Is there any formula like this? There is no clear formula like this, because there are many factors involved, especially transcellular shifts. Once there are transcellular shifts, it is very difficult to estimate the total deficit, because you lose to the kidneys, you are moving into the cells. So there is no clear-cut formula. Certain formulae have been given which give a rough approximation, but the ideal way is you replace potassium, you check potassium, you replace potassium, you check potassium. So this I think I've already covered for you, and now we are coming to hyperkalemia. So before I come to hyperkalemia, any comments, sir? Any experiences, any approaches to hypokalemia? Anything you want to add? Anybody from the faculty, please?
Dr. Bansal, regarding your correction about the hypokalemia in respect of hypomagnesemia, so sometimes very often there may be a hypocalcemic state also. So that's why that along with that hypokalemia, if it is refractory or not correcting, or patient is getting some drugs, or like your diuretics, or sometimes patients are having diarrhea. So these patients are or alcoholic. These patients are potentially hypokalemia as well as hypomagnesemia is common, along with the hypocalcemia is also very common in these cases. So that time the correction should go in all aspect. So
yes,
that is what I can just
Yes, sir, that is very true. Sometimes when you have hypokalemia, hypomagnesemia, there is a pan-hypodyslectrolytemia. Even phosphate becomes low. And you mentioned alcoholics. Alcoholics are classic cases. They have hypokalemia, hypomagnesemia, hypophosphatemia because of poor nutrition intake. And alcohol itself, high alcohol intake causes a diuresis kind of a picture, and they keep losing electrolytes. Similarly, diabetes poorly controlled because of polyuria, they also have pan hypoelectrolytemia. So I agree with you. Definitely, you have to look at the other electrolytes when you have hypokalemia and hypomagnesemia. Phosphate also has to be seen along with your calcium. So the electrolytes have to be corrected. Absolutely right. I agree with you. You have to look at your calcium and phosphorus also. Any other comments, sir? Inderpaul Singh, sir?
No, it's okay.
Dr. Reshu, you want to say anything?
No, I think you have covered everything in hypokalemia, and in between we had the discussion. So I hope it's very much clear to our audience.
Okay, so I will move on now to hyperkalemia. So hyperkalemia, the physiology for potassium, I've already told you. Now the question is, why does my patient have hyperkalemia? So it is important, first of all, to look at the kidney. We all know that acute renal failure and chronic renal failure. Then, sometimes the creatinine is not elevated. There is only a hypoperfusing state with a decreased renal flow. In these patients also, your potassium can go high. Then I would like to talk about diabetes per se. It causes type 4 renal tubular acidosis, wherein you get a state of deficiency of aldosterone. So sometimes, it is not so uncommon. You get a diabetic patient. He will not be having an elevated creatinine and urea, but his potassium will be around 6. So this is actually because of diabetic nephropathy manifesting as hyperkalemia due to decreased aldosterone levels. And this is actually type 4 RTA. And this should be recognized that this is because of diabetes, long-standing diabetes. Then sometimes, patient takes in fruit juices or citrus fruits, GI intake can lead to transient increases in potassium levels, especially if you are predisposed. Then certain drugs can cause hyperkalemia. Acid-base balance we have already talked about. Transcellular shifts also we have talked about. Aldosterone disorders come in various shapes and sizes. Either you can get hyperaldosteronism or you can get hypoaldosteronism. In these, the aldosterone levels may be increased. Like Madam, I just told you about the Conn syndrome. They had one case, hyperaldosteronism. Then you can get actually genetic defects in the tubules with normal aldosterone levels, which can lead to hyperkalemia, and the other way around, depending on whether the aldosterone is increased or decreased. So aldosterone is a key factor in potassium, but the disorders of aldosterone actually, which are more complex, are not within our purview, but we should know that aldosterone is actually a key determinant factor, which I told you earlier in my initial slide. And then cell lysis causes hyperkalemia. Now, please look at the kidney when you are having hyperkalemia, because 75% of the time the kidney is at fault. So what are the drugs which cause hyperkalemia? You have your NSAIDs, COX-2 inhibitors, beta blockers. Then you have your ACE inhibitors. Then you have your angiotensin receptor blockers. And then you have your spironolactone. So they all act actually at aldosterone. So aldosterone again is a key factor. And then you have amiloride and triamterene, and very important is ceftriaxone, trimethoprim, which is sometimes used as an antibiotic, and pentamidine, which you use in HIV patients for PCP. So this IV ceftriaxone is again, we use in patients who have unusual organisms and you get sensitivity, or we use it for HIV. It is not uncommon to use IV cotrimoxazole in HIV patients, and they go into hyperkalemia. It is quite common. So we should be aware of these drugs. Then other drugs are cyclosporin and tacrolimus. Sorry, there's an error in printing. Then scoline. We all know scoline. You avoid scoline in patients who have neuromuscular disease or who are immobilized. Tacrolimus, the use of cyclosporin and tacrolimus has become much more common. Digoxin toxicity causes hyperkalemia, and digoxin interacts with potassium because they bind to the same receptor on the cardiac cells, and then beta blockers. And then the rare causes are blood transfusion. Blood transfusion also causes hyperkalemia because the stored RBCs release potassium, and if there's massive transfusion, it can lead to hyperkalemia. And Gordon's syndrome is a rare disorder of hyperkalemia, which is a tubular defect. Now, ECG can be normal even with severe alteration in serum potassium. This should be known to everybody, that textbooks often describe that, at such and such level of potassium, you will get such and such ECG disturbance. But that actually is not true. You can have a normal ECG and with a potassium of 6.5, and the patient can have a cardiac arrest after half an hour. It has happened in my ICU. It has happened in all the ICUs. I'm sure many of you have seen this. So ECG cannot be used to give you a false sense of security. So if the potassium is going more than 5.56, you have to correct the potassium. Or if it is going low. But the higher potassium is more dangerous rather than the low potassium. And VT-VF, we know, occur with both hypo, but it can occur with hyperkalemia also. Classically, hyperkalemia presents with complete heart block. And generally, you see this in the setting of CKD, and you put in a TPI for your complete heart block, you dialyze the patient, and you can remove the TPI, patient becomes okay and can go home. So that is a classic presentation of hyperkalemia. It presents with complete heart block. But it can also cause VT-VF, and hypokalemia, I've already discussed, ST changes, U wave changes, and they degenerate into torsade, or they can degenerate into monomorphic VT. So ECG should not be used to guide treatment in terms of a normal ECG. You have to look at the serum value of potassium. Then coming to the treatment of severe hyperkalemia, the treatment of severe hypokalemia, 10% calcium gluconate. This should be known to everybody. This is very clearly written, I think, and you should read it for yourself. Calcium is to be given if there are ECG changes. But if the potassium is really going high, there is no harm in giving potassium, and it acts by stabilizing the membrane. And you should know the difference between calcium chloride and calcium gluconate. Calcium chloride has 3 times the amount of calcium that calcium gluconate has. And then transcellular shifts are caused by insulin. And when you give insulin, you have to give a 50% dextrose, 50 ml, and then you have to follow with infusion. And please check the sugars after that, because sometimes they go into hypoglycemia, because these patients are often sick and they're malnourished and they're already having low sugars. It is not uncommon. So please follow up the sugars in these patients. They go into hypoglycemia. And then potassium removal, if you see here, they have written sorbitol. So this sorbitol is not actually recommended anymore, because one of the side effects of K-xylate is what? Does anybody know the side effect of K-xylate? One of the side effects is occasionally it can cause intestinal necrosis. Occasionally it can cause intestinal necrosis, especially if the GI tract is involved in that patient. So this sorbitol was actually given to decrease constipation and remove the K-xylate along with the potassium that it binds in the stool. But sorbitol was found to contribute to intestinal necrosis. So K-xylate, you please give it plain water, and to avoid constipation, if there is constipation, you can give some other laxative which is not having any potassium or not harmful. So the maximum dose of K-xylate is 30 gram 6 hourly. So you give your insulin 6 hourly or 4 hourly, you give your K-bind 30 gram 6 hourly. This is the maximal kind of dose. And then for your immediate effect, please use nebulization. You can use up to 10 milligram of salbutamol in 4 ml and nebulize, and the effect comes immediately. And the effect I told you is through transcellular shift. And the other thing that can be used is then Lasix. If the patient is passing urine, and of course dialysis is the last resort if the patient is not responding and is in renal failure. So this is about the treatment of hyperkalemia. And if there is acidosis, you can also use some soda bicarb. But when you use soda bicarb, please do not give it in normal saline along with it, because then you will cause hypernatremia, and along with it, the alkalosis can cause hypocalcemia. So you should be aware of this. Soda bicarb should be diluted with 5% dextrose. So when you give IV soda bicarb, please be cognizant of this. 50 ml contains 44 milliequivalents of bicarb and 44 milliequivalents of sodium. So this should be taken care of. The other electrolytes should not get disturbed and cause harm when you're correcting hyperkalemia. Now, what is the dangerous level for potassium? The dangerous level for potassium is more than 5.5 or 6 for your hyperkalemia and less than 2.5 for hypokalemia. So please be careful with potassium, and there should be no deaths because of low or high potassium. It actually reflects the level of care, and unfortunately, every ICU, I think, once in a while has a death more because of hyperkalemia rather than hypokalemia, and that is actually avoidable. But you have to be cautious and vigilant, and I think that is all. So whatever questions are there, we will take. Please put it in the chat box, and and whatever comments are there from the esteemed panelists, I would welcome the comments and their experiences.
There's a question in the chat box. Do vasopressors have a role in hypokalemia? Am I audible, Dr. Bansal?
So are there any... Any comments?
Dr. Bansal, basically they have asked for any role of not role exactly, any change of your potassium level if the patient is on any vasopressor like adrenaline, noradrenaline, or like that any other vasopressor.
Yes, there can be minimal effect. Like beta agonist effect is there. Then beta agonist effect is known to promote movement of potassium into the cell from outside. So you can say yes, mild hypokalemia can occur on high dose infusions of your epinephrine or your noradrenaline, but this does not actually amount to clinical significance. But definitely theoretically, your beta effect promotes beta agonist effect promotes movement into the cells. Definitely, yes. So, any other questions are there? I request everybody to put on the videos. Cannot see anybody. So, any more questions? So vasopressors don't have any role in hypokalemia, right? Dr. Shankar, vasopressors don't help in hypokalemia, but they can cause theoretically some degree of hypokalemia. Epinephrine, like I told you, can cause some degree of hypokalemia, but it is more theoretical.
There may be another reason that patients may feel helped by answering this. What should be the frequency of sending potassium level to the lab, or rather, what will be the difference between the lab potassium and the ABG potassium? Many of the time, the ABG machines are not so much well calibrated, so we do not come to know the exact level of potassium from ABGs. So, what should be the, interval of sending potassium to the labs for any hyperkalemia or a hypokalemia patient?
No, see, the ABG has to correlate with the, if the ABG is not correlating, there can be a minimal difference of 0.2, 0.3, but the ABG has to correlate. The machine, if it's not correlating, then you have to rely on serum values. I know the ABG in our ICUs are often not calibrated. That is the problem of the lab people who are not calibrating the machine. So if the ABG is not giving the potassium value properly, then you have to go with the serum values. It has to correlate. There can be a difference of 10%. That's all at the most I can say. They cannot be 100% agreed. There are two separate indices for measuring two separate machines. But at the most, you can have a 10% difference. That's all I can say. The machine has to be calibrated. In fact, what potassium, the machines sometimes don't even give your pH and your O2, CO2 properly. So you have to be after the lab to maintain the ABG machine properly and calibrate it.
Yeah. During correction of severe hypokalemia, like if the potassium is less than 2 and all, the textbook says that it should be checked every hourly or 2 hourly. But how?
Yes, I think you will agree. It has to be checked frequently. See, textbooks only give a broad outline, but definitely when it's less than 2, you have to check at least 1 hourly to 2 hourly till it starts rising. Severe hypokalemia is defined as less than 2.5, and you can look at your clinical picture, whether he's having quadriparesis, whether the ECG picture is not good, and once the potassium is gone beyond 2.5 and his symptoms are better, ECG is stable, then you can revert to your 6 hourly monitoring. But prior to that, 2 is a very dangerous level, and something like 1 to 2 hourly monitoring has to be done.
But practically, doing potassium 2 hourly, what we in practice, what we do is we do a potassium, like if we are replacing the potassium by a central line, or we are replacing it.
Any more questions?
Just for the audience,
yes,
and as well as what we are discussing about the frequency of the potassium, this if we do the potassium level, definitely in ideal world, it should be done for hyperkalemia or severe hypokalemia when there is cardiac manifestations. Definitely, every hourly you have to check. Maybe even 30 minutes also you can have a check to find out, because if the course of the disease is like that, patient may deteriorate also, particularly in the background of renal failure. So, but problem is another here because we are working in some of the private institutes. So in the private institute, more and more number of tests that should be justified also, because ideally if you send potassium in a day, say 12 hours to 12 potassium, so sometimes very difficult to justify to the attendant or family members. So anyway, there is these things should be judged. Another thing is that about Dr. Leelawati, as well as we are discussing about the potassium in the ABG as well as potassium in the your serum value. Ideally, if we are calibrating regularly, so that should match little bit. There may be minor deviation because of the heparinization or other things. But the corporate or the private institute, they never encourage these things because there is a separate revenue generation from that hyper. That is to be very frank. That is because if you are basically getting a sodium, potassium, lactate, everything, even chloride from the ABG, and you are treating, there is no need for the serum sodium potassium checking, and there is a revenue means model. There will be definitely some reduction in the revenue collection of the corporate hospital. So that's why I think there may not be very encouragement in checking as well as calibrating the sodium and potassium level. And lastly, just one thing what I was thinking about sometimes there is one thing, serum as well as plasma potassium level. So if you're regarding that hyperkalemia, pseudo hyperkalemia or pseudo hypokalemia, so if that is doubtful, because sometimes that can vary with 1 to 2 milliequivalent per liter variations on the result. So that time you can check the heparinized solution for the plasma potassium as well as the serum potassium. Usually that plasma potassium will give a correct value most of the time. So the pseudo hyperkalemia effect can be negated.
Thank you, Dr. Panja, for your nice comments. So, Dr. Inderpaul, sir, your comments, some words of wisdom from your side?
I think most of the topic is well covered, except for the fact that sometimes in severe hyperkalemia, one may have to resort to hemodialysis, even though there may not be the indications for doing hemodialysis. But for refractory hyperkalemia, one has to resort to hemodialysis if it is not showing any effect with the usual care. Another thing is that you may also try loop diuretics that will take care of potassium if the urine output is adequate. So those are the two things that I think one can look into if the potassium is not responding. As far as hypernized sample is concerned, if you over hypernize the sample, it can also give you false values of potassium. Heparin itself, if you are giving, can cause hyperkalemia. So that's a common cause that we also see patients having hyperkalemia, and that's a drug which is commonly used in most of the ICUs as for DVT prophylaxis and often overlooked as a cause of hyperkalemia. So I think most of the things have been fairly discussed. In fact, quite broadly discussed. So there's nothing much to add.
Yes, sir. Yes, your point is well taken, Dr. Inderpaul Singh, sir. Heparin also, which is going on for some time, can cause hyperkalemia, and I think it also acts through aldosterone only. It inhibits aldosterone, and it causes hyperkalemia. Point is well taken. Heparin is a drug we use commonly, and that can also contribute to hyperkalemia. So, Dr. Leelawati ma'am, your comments finally.
I think till now we have discussed, you have discussed is in quite a lot, at length and breadth of hyperkalemia. Another thing, just to comment on feeding syndrome when the patient is severely malnutrition, having severe hypoelectrolytemias. So this can another thing that actually with polyelectrolyte imbalance, refeeding syndrome may be a thing that we need to talk around. particularly if the patient is having a hypophosphatemia and hypomagnesemia along with hypocalcemia and hypokalemia. So this thing we need to take into account whenever we are correcting all the multiple electrolytes.
Yes, definitely, ma'am. That repeating syndrome causes the hypophosphatemia and all the electrolytes, because actually insulin gets secreted, and insulin causes the transcellular shift for all the electrolytes, potassium, phosphate. Definitely, repeating syndrome is an important cause of hypokalemia. Definitely. And ma'am, would you like to share the experience with Gittleman syndrome? What exactly was the patient?
We have seen almost 3 to 4 patients till now. 2 of them were in my previous issues. We had gone through the same algorithm to, diagnose all those.
No, that is, how did the patient come to you with hypokalemia?
Hypokalemia, yes.
No, the potassium was
one like hypokalemic periodic paralysis, and another in a severe, almost what to say, it's kind of a refractory hypokalemia. We had to give a lot of, almost 200 to 220.
That is what happens. The potassium can be. So
what was the presentation? What was the presentation?
Outside potassium reports, or just first time presentation?
This was a first time presentation. It was not a repeated one.
Okay, ma'am. So I think there is some genetic factor there in your area. They're very interesting.
Maybe.
No, definitely, because we have not seen in this area, because this is a genetic mutation and it carries in the families. So definitely there is some pocket there.
And, how did those patients present to you?
Anyway, thank you for sharing your experience.
How did the patient
Dr. Reshu, ma'am, your comments final before we close.
No, I was just asking Leela ma'am, how did the patient presented?
That was kind of.
They had,
yes.
Okay. So as for the presentation, Dr. Bansal, I think you have covered almost everything and very much in details. One thing which, yes, you had rightly mentioned about one thing which I...
Dr. Reshu, are you there?
Yes, I am. Am I audible? Am I audible? I'm here.
I don't know. She's not responding. So I think then any questions, audience? Any questions? Please, if you have any final questions, we'll take them. Otherwise, I think we are coming to the end. It is almost 7 o'clock also. So I think I've answered the questions, whatever were there. A few questions were there. And overall, it has been a nice experience. And I thank the esteemed panelists, Dr. Panja sir and Dr. Inderpaul Singh sir and ma'am and Reshu ma'am. Thank you very much for sparing your time and enriching our experience. And I think the audience also found it useful. I hope we have been able to help them. And the recording will be put up on our YouTube channel. As you know now, we have put up all the recordings, past recordings, and future recordings will be available on Young India Intensivist YouTube channel. And finally, I thank Sipla for supporting us technically. Thank you very much, everybody. Thank you very much. Next topic is going to be ultrasound of the lungs, and same time, same link, and to be taken by Dr. Shrikant Srivasan, who is actually an expert in ultrasound and has written a book actually on ultrasound in the ICU. So I hope you can join us, and it'll be a workshop kind of a thing, and hone your skills in ultrasound, because it's becoming very important to know ultrasound of the lungs. So see you again next week. Bye-bye. Take care. Thank you, everybody.
Thank you.